Good morning, everyone. Welcome to our Department of Medicine lecture series. And we are continuing our lecture series on ECG basics. And we have with us Dr. John Vijay Jayachandran, sir. He's been with us for the last 3 weeks. Today is going to be the fourth part of that ECG basis. And as usual, sir would like to keep the sessions as interactive as possible. And if you have any doubts, you can ask right during the session, or you can put down your questions in the chat box and sir will be happy to answer towards the end of the session. Over to you, sir.
Thank you, Nitin. Good morning, everyone. So this is the fourth, and I think this would be the last of our series here. Today, I wanted to focus on wide complex tachycardias. To date, we have looked at just the basics of EKG, rate, rhythm, axis, wavefronts, how EKGs are collected, so forth. And then we looked at a few basic Brady arrhythmias, some type 1, type 2 block, and some complete heart block. And then some atrial arrhythmias we looked at, as well as some SVTs, different types, short RP, long RP tachycardias, and a few examples of artifact. And today, I thought we'd spend some time on wide complex tachycardias. So, with all of these ECG reading techniques, I think the main thing to do is, my main goal is to just transmit some concepts. And then as you look at the ECGs over time, you'll just get more and more competent at it. So all of you have already had lots of experience, but I will tell you, I'm still learning every day. I definitely learn something new every day on some ECG or some rhythm tracing that I'm kind of confronted with. And I still have tracings every day that kind of stump me and I have to kind of stare at for quite a while to figure out. Now, when you look at wide complex tachycardias, I think this slide is very helpful. So it's basically to remember what a left bundle looks like and what a right bundle looks like in V1. V1 turns out to be a very helpful lead for looking at wide complex tachycardias. So remember that a typical right bundle has an RS R prime, with the R prime being taller than the R wave. So that's the typical right bundle. And if you look over in the V6 lead, it's going to have an RS complex. But let's focus just on V1. I think that's what's most important. Remember, in a normal V1, you hardly have any initial R wave at all. It's always less than 40 milliseconds, so less than one small box typically, and then you get a sharp downstroke. Similarly in right bundle branch block. Now in left bundle, you never have, you typically do not have any positivity. You just have a sharp negative deflection. And even this is, I think, not exaggerated enough. We should show this as almost a vertical straight down line to exaggerate this. That in left bundle, you have very sharp downward deflection in V1 with definitely less than a 40 millisecond R wave initial in the V1 complex. So this is a typical right bundle. I'm talking about just an average typical right bundle branch block and left bundle branch block. Now,
So slides are not visible.
Sorry?
So your slides are not visible, sir.
Ah, sorry. Okay, hold on. Let me get out of this. Let me just go back. Let me try resharing. I thought I picked it, but okay. All yes, is not lost. Fear not. How about now?
It's there now.
Yeah. Next time, feel free to interrupt me anytime. So, typical right bundle, RSR prime, typical left bundle, sharp downstroke with the kind of a QS complex in lead V1. So always use lead V1 to think about these right bundle branch blocks. I haven't really shown any other slide. This was my first slide. Now, when you look at this, I want you to kind of imprint in your mind that the R prime is taller than the R wave in a typical right bundle. Also imprint in your mind that there's a very sharp downstroke, and try to picture this as exaggerated, that almost going straight downwards in lead V1 for a left bundle. And that this initial R wave, there's nothing here. You see that? It just comes straight down. So that initial R wave, any initial positive, should be less than 40 milliseconds. Now, when you look at wide complex tachycardias, it's very helpful to group them into two main categories of morphology, talking about shape and size or what it kind of looks like overall. Obviously, a very basic differentiation would be between regular and irregular wide complex tachycardias. Let's focus most of our energy on regular wide complex tachycardias for now. Now, when you look at a regular, you need to decide, is this SVT or VT? That's the primary issue, right? When you have the wide complex tachycardia, and you'll see this in your emergency room in the casualty, someone shows up with wide complex, make a decision, because that'll help you decide what to do down the road. Now, when you look at these, club these into two main groups: right bundle type wide complex stack and left bundle type wide complex stack. So right bundle type wide complex tachycardia will always, the terminal part of the QRS complex will be positive in a right bundle branch block type wide complex tachycardia. In a left bundle type wide complex tachycardia, the terminal part of the QRS complex would be negative. So now you have a nice way of differentiating between the right bundle type of wide complex stacks and the left bundle type. And this is a very helpful and useful differentiation. And you need to understand that so that when you look at a table telling you how to distinguish between different types of wide complex stack, you know what you're looking at. So it's the terminal part of the QRS complex that decides what type of wide complex stack you're looking at, okay? So again, a typical left bundle, look at this, almost no initial R wave, very sharp downstroke in the initial onset of QRS complex here in lead V1. Also note here in lead AVR, this is another helpful lead to look at deciding if this is VT or SVT. We know this is sinus tachycardia with left bundle because it's a typical left bundle branch block, a very sharp downstroke, almost no initial R wave. And when you look at AVR, it kind of looks the same, like a very sharp downstroke over here, okay? So that's a typical left bundle type morphology, typical left bundle branch block morphology. Here's another example of that. Again, you can see the very sharp downstroke. There's another thing I want to point out here. Between the onset of the QRS and the nadir at the bottommost part of this QRS complex, that time interval from there to there, from there to here, is typically less than 70 milliseconds or less than from whenever your QRS complex starts to when you hit the bottom of your QRS complex. That's onset to nadir is less than a couple of little boxes, or let's say less than 70 milliseconds. It typically 40, 50 milliseconds, and you're already down at the bottom of it. Very sharp downstroke. Now you look at a typical right bundle, you have an R, S, R prime, okay? And if you have you look at AVR in a typical right bundle type rhythm, and you'll see a sharp downstroke and a terminal R prime, almost kind of mimicking the V1 complex in lead AVR. Okay. AVR helpful lead to look at as well for distinguishing between VT and SVT. So here's my first patient. So this one's from this year. So unfortunately, it's a COVID special. So here's a patient shows up in the ER with COVID, and the first night on telemetry, this was one of the rhythms recorded. Let's take a volunteer, and then we're going to look through a couple of slides on this patient here. You guys will have to jump in quickly. I got a bunch of slides to go through. So you can jump in and then just start kind of talking through it, and then we'll walk through it together. You don't have to kind of nail down every part of the tracing. Just give me some general observations. I'll make it, let's keep it kind of general at this point.
Reba, would you like to take this?
the rhythm in 1, 2, and 3 is not very regular. I mean, the interval between the QRS complex.
Okay. You're talking about the left side of the screen here?
Left side of the screen.
Okay. All
in
right.
the lead to the bottom, it starts off as irregular morphology changes.
Okay. Then what do you think is happening over here? Yeah, okay. I didn't really put this up as a trick tracing. I wasn't trying to fool you here, but these are the P waves. This is the P wave. This is the P wave. Here's a P wave. Here's a P wave. Now, what do you think?
After a point, all the P waves are not followed by QRS complexes.
Right. So complete heart block, right? So complete heart block, correct? No QRS complexes, just P waves only, the rest of the screen. These are not QRS complexes. These are just, they're just large P waves. They're just gained up by the EKG machine a little bit, but it's all P waves, complete heart block. Do you see that?
Yes, sir.
Okay. So a patient comes in with COVID, fevers, on overnight telemetry, and then this was actually captured on a 12 lead, if I'm not mistaken. Yeah, this is a full 12 lead. Yeah, I think we've got all the leads. And they kept doing this. And so that was the first tracing. And then a few minutes later, same patient does this. So now you have to decide what kind of rhythm is this, and what are we going to do about it? Patient is still conscious and has a blood pressure of, like, say, 100 systolic, and starting to look kind of glassy-eyed. So you have to kind of decide what to do. Maybe we'll think about what to do later. First, let's decide what the rhythm is. May I ask you questions? Is this narrow or wide complex tachycardia?
Wide complex tachycardia.
Good. So wide complex tach. So let's just call it regular for now. I can't really tell. I don't have a marker or anything to tell me very clearly. So let's just call it regular for now. Okay. And it's a regular wide complex tach. And is this a left bundle or a right bundle morphology? For that, remember, you have to look in V1. And I might be playing a little bit unfair here. It's kind of a squishy, smushy, awful looking V1. But this is real life. This is what you get. You're also going to get the same tracings. No one's going to get perfect 12 lead EKGs of people in wide complex tach. So what do you think? Look at this V1. What is your feeling? This is left bundle type or right bundle type? Maybe look at just these two complexes.
The QRS is actually downgoing, the terminal
Good.
part. So it has to be
Good.
a LVP morphology. Very
good. So left bundle type, wide complex tachycardia. Okay. So now, what do we make? What shall we do with this? Here's what we should do. We should try to think: is this a typical looking left bundle and suggestive of a SVT, like a flutter or something like that, conducting down with a bundle branch block, a left bundle, or is it VT? And are there any other clues on the tracing? What is your feeling on that, on this topic? You think typical or atypical for a left bundle? Does it look more like a normal left bundle branch block complex, or just not those usual criteria? Which
doesn't look normal, sir.
Doesn't look normal. Good. So you imprint in your mind a typical left bundle, and this will be no problem at all, this tracing for you. Okay. So look at V1 over here. So this is where it starts. Let's say on this complex, let's take this one. Okay. So it starts over here, and it's a very gradual downsloping, and probably takes about 2 boxes to get over here if you really see the true V1. And I apologize for the awful V1 here, but we'll come to a few more clean tracings. But a slow downslope in V1. Now, Here's another criteria, and this was written by a fellow that I knew in Indiana. He was from Hungary, Andras Verekis, a brilliant criteria, Verekis AVR criteria. And if you look in AVR, if you have a gradual downslope, downsloping like this, then this is ventricular tachycardia. If you don't have a sharp downslope, if you have a gradual downslope, this is VT. Okay, so when it's atypical, it's VT. There's one more clue over here someplace. So let's look down at this lead in V5. Any clues you see in V5? Look at this part of the tracing. See if you can make anything odd, which I will grant you that it's not 100%, but it's kind of suggestive. It's a possible. I didn't really talk much about any V5 criteria. I'm thinking more of the rhythm. And if you look at the rhythm here, look at this. What's this doing over here? This looks like a P wave out of the blue. You agree? And sometimes you see it, sometimes you don't in the ST segment. So the important place to look for P waves is between QRS complexes. And if you start seeing P waves that appear at some times and don't appear at other points in the tracing where it should be, if this is a bump in the ST segment, then you should kind of see it consistently on every ST segment, but you don't. So this is a good candidate for what? This is a good candidate for a P wave. And if this is a candidate for a P wave, and there's no P waves here and another P wave over here, what does that make this rhythm? SVT or VT?
VT.
Ventricular tachycardia, good. Because the P's, the atrial rhythm is completely dissociated from the ventricular rhythm. It has nothing to do with it, if indeed this is a P wave. I will grant that I can't prove it right now. I'd have to give you some more information to prove it to you, okay? One more feature of wide complex stack that suggests VT rather than SVTs. If you look at lead 2, the timing from the onset of the QRS to the peak of the QRS, you can see is 40, 80, 120, almost 120 milliseconds worth of timing between onset and the peak. And that's very long. Typically in an SVT, you get a much sharper upstroke. In a VT, you get a slow upstroke. And the slower that upstroke is in lead 2, the more sure you can be that this is ventricular tachycardia. And I'm going to give you a little table here so you can remember that. And I'll give you a reference that you can look up as well. Here it is. Let me make sure that I didn't miss a slide there. Good. Okay, I like this one. This was a table I just found recently here, and it's not that new. It's from 2019 from the ESC. I'm not sure if you're familiar with this, but it's easy. It's downloadable from your it's a free PDF. And here are some helpful criteria to kind of keep in mind for SVT versus VT with a wide complex stack. Okay, and remember, you need to keep the concept in your mind. You don't need to memorize a million criteria. You just need to keep the main ideas in your mind. Okay, so if there is AV dissociation, we know we have VT for sure. Okay, if the A's have nothing to do with the V's, then this is VT, and it's a wide complex tachycardia. Specifically, if the ventricular rate is greater than the atrial rate, there's AV dissociation with the V going faster than the atrial rate, then we know we're in VT. Now, if you have fusion or capture beats, we'll talk about that. And that means in the middle of a run of VT, you suddenly have a skinny QRS. What that means is that a P wave from the atrium conducted down to the ventricle, and you have a capture. And that could be a partial capture, which could be a fusion beat, or a full capture called a capture beat. Okay. Negative concordance simply mean that from V1 through V6, everything is negative. All complete downstroke negative, okay? So that's complete negative concordance. And then there's some RS criteria if there's no RS in any lead, or if you do see an RS, it's very prolonged over 100 milliseconds. AVR criteria, I'm going to show you a picture, an image, so you can imprint it. It's hard to remember these numbers in your head. It's easier to remember an image, I think, and I'll show that to you. Northwest axis over here. And then we talked about this. In lead 2, the R wave peak time is greater than 50 milliseconds. So slow time to peaking in lead 2. And remember that in right bundle morphology, if you have an RSR prime and the right, so if the left is taller than the right, then you'll have a problem. That means anything other than the typical right bundle is going to be VT. Typical left or typical right bundle more likely to be SVT. Same story for left bundle. We already talked about this. If you have a big fat R wave and a left bundle type, and you have a slow downstroke, delayed nadir of the S wave, then all of those are going to be VT. In right bundle, instead of RSR prime, if you have an R being tall and the R prime being short, that is the left side or the left rabbit ear being taller than the right, then that's atypical and that more in favor of VT. Okay. Hope that's clear, but let's look at a few more examples. Now, I like this Verrecki criteria, maybe because I know the guy who was a fellow with us in Indiana and really brilliant guy, and came up with this criteria, Verrecki's AVR. So if you have SVT and look in AVR, you're going to have an RSR prime, almost like a typical right bundle. You agree? This looks like a typical right bundle here. Whereas if you have a QS that's very fast, like a very typical left bundle, these are SVTs. So imprint this in your mind for AVR, and everything else will be VT. If you get a fat monophasic R wave, or you get a slow downslope in the QS, then these are the two commonest. These are going to be VTs. And all of the others will kind of follow this pattern or this pattern. Slow downstroke, QR, big monophasic or big monophasic R wave, all of these will be VT. So imprint in your mind what an SVT is, and everything else is going to be VT. What is an SVT in AVR? RSR prime looks like a typical right bundle, or sharp downstroke like a typical left bundle. Okay. If you read the paper, it will drive you a bit batty because it's a bit confusing. So I asked somebody to read it and they got pretty dizzy looking at it. So I think the picture is worth 1,000 words. Okay. Let's get a volunteer, and we won't spend too much of time on this. We'll just kind of take a quick look at some of the main criteria. I'm going to have to tell you what the leads are. Looks like they're going to here. While the next volunteer is thinking about it, this is lead 2, this is lead 3, this is lead 1. This is V1. This is V1 here. This is lead AVR here. And L and F. Okay. So obviously telemetry decision to be made. And these are not fabricated tracing. These are all ones that were sent to me on my phone or on my fax machine, and was asked to make a decision about what the rhythm was. So now it's up to you guys. I'm sure you can do it. Volunteer?
Kartika? Thomas, would you like to take this?
Yes, sir. It's like a tachycardia with a sinus origin. I can see P waves in some of the leads. Then the QRS complexes are also, it's wide, but the pattern I'm not able to make out.
Okay. Okay, good start. So you're saying, I think you started saying something about sinus and that you could see some P waves. And I was trying to see which ones you were talking about. In which lead
So
are you
the-
seeing P waves?
From the bottom, the third lead
Okay, this lead here,
on the left, yeah.
over here, on this
Yes.
side.
Yes.
Are you referring to this little glitch
Yes.
here?
Yes.
Ah, okay, okay. All right, okay, I see what you're saying. Yeah, okay, I see that there's something there that looks like, okay, maybe that's a P wave, don't know yet. We'll find out. And then after that, you said maybe it's a sinus stack. And so do you think there's one of those for everyone? I'll tell you, it's not a bad start to look for P waves. I think it's a good idea always to look for P waves. And when I looked at this tracing, I said, I'm not quite sure where the P wave is. All I can see is there's some kind of rhythm, fast rhythm over here. And then remember, whenever you're given a rhythm strip of any sort, always look at the beginning and the end, like where it starts and where it stops. And that'll save you a lot of time and a lot of headache, okay? So always look at, so what happens after it ends? Any comments on what you're seeing on this right side here? It seems to break, correct?
Yes.
Okay.
And then there seems to be a pattern like an atrial flutter kind of pattern, the sawtooth.
Yeah, so that's the problem of looking at telemetry strips. So when you look at tele strips, when you have all these little fuzzy things over here, that's all just noise. That's not any kind of P wave. Okay, that's just electrical noise, artifact. And you will encounter the exact same problems when you look at tele strips in your ICU or in your ER when they come in. If you print them, they'll have all kinds of noise on them. You got to figure out what's P wave, what's not. Now, when you look here, what I can tell is after it breaks, there's at least one skinny looking beat here. You agree?
Yes, sir.
Okay, so it looks like maybe a normal QRS over here.
Yes, sir.
All right. And then in front of it, lo and behold, there's like a pretty good looking P wave over here. You see that? There's a nice P wave right in front of it.
Yes, sir.
Okay, so here's a nice P wave and here's a good QRS. Okay, so now we know what this gentleman's normal looks like. That's his P and that's his QRS. So now you gave me the problem of trying to figure out what that little notch was over there. So now I come to that same lead, AVR, when it stops, and I say, okay, this is his normal P wave and that's his normal QRS in AVR. Does that make sense for a normal P and QRS in AVR? I don't want to trip you up, but that's pretty normal,
No,
right?
yes,
We
yes.
usually have an inverted P there and a QRS that's negative there in AVR. So fine, okay, I agree, that's a normal P and QRS. Now look at that P wave and now walk it over here and then look, could this be the P wave?
No, sir, it won't be the.
Yeah, so it's tough to
apologies.
call that a P wave. That one looks positive, this one looks negative. So maybe not, tough to tell, okay?
Yes,
So here's my feeling, and we'll come back to that P wave here in a second. So the other fact you mentioned is that, hey, look, this looks like a wide complex tachycardia, and I completely agree with that. It looks wide. And it doesn't look that wide, frankly, when you pick up the tracing, especially on this side. If you just had this lead, you'll say, well, I don't know, it looks a little wide, I'm not sure. But now that you have a narrow complex here, this is then definitely wide, correct? You can
Yes.
you can see the definite wide. It's unfair of me to ask you to count here, but it's probably right at 120, 130 milliseconds. So barely makes a wide complex stack, but it's wide. So let's say it's 130 milliseconds. You can see his intrinsic QRS is very narrow. So it's a wide complex tachycardia. And if I'm not mistaken, what leads did I give you here? This is lead V1. This middle lead right here, this is V1. Do you see my pointer?
Yes, sir. Yes, sir.
Okay, this is V1, okay. And this is lead 1, 2, 3, V1, AVR, AVL, AVF. So this wide complex stack, is it a right bundle type or a left bundle type wide complex? What morphology? In general, is this a left bundle branch block looking or right bundle branch block looking? Which lead do we look at to decide that?
V1.
V1, good. So in V1,
Yes.
if it's most of the QRS here is pointing upward or positive or negative?
Positive.
Positive, okay. So positive QRS in V1, and certainly even the terminal part of the QRS, the entire QRS looks positive in V1. And so let's call this a right bundle type white complex stack. So now we have to decide, does it look like SVT or VT? Maybe focus on these few beats over here. This is a little bit cleaner. Does this look like a typical right bundle or atypical right bundle? Remember that in a typical right bundle, you have R, S, R prime, with the R prime being taller than the R. That means the second one is the R prime.
Yes.
Okay. So this one, which way is it going? It looks like R, S, R prime looks a little shorter. Do you agree?
Atypical.
Even though it's all squished together, you can see R, S, there's a little slitch of an R wave, S wave there, and then an R prime here. So very atypical looking right bundle in V1. And you remember our Verrecki criteria. Verrecki said that in lead AVR, if you get a big fat monophasic R wave, then this is always VT. You could have gone with Verrecki and you'd be almost 99% sure that this is VT, just looking at this AVR.
Yes.
It makes that criteria very nice. And V1 also is very helpful. Now, there's one more little piece here, and I'm glad you picked up the P wave, because I do think that could be a candidate for a P wave. It just said it's not a sinus P wave. I think there's a little glitch over here. You can see that in the slope of the ST segment, there's a little notch there. So I think this is part of a P wave. We're not seeing the entire P wave. This P wave definitely could not have caused this complex because it's too close to it. So we know it had nothing to do with this. And then when you kind of scroll through, you always look inside these ST segments in the interval between QRS and QRS. That's the place to look for P waves, right? Between R and R. And look at this, there's some kind of little notch over here. And I think if you followed this out, you'll see, I don't think there's an exact pattern to match it out, but every now and then there's a candidate for a P wave. There's a little notch there. And so again, this suggests AV dissociation. It's not a one-to-one association of the P and the QRS, and the V is going faster than the atrial rate. Okay?
Yes.
I can't show you any other P waves nearby to show you that the V is definitely faster, but you'll have to take it from me. I think there's possibly one candidate somewhere over here where there's a P. Yeah, here's one right here. I think this is another P, this is one P, and so forth. So you kind of have to, it might sound like I'm stretching my imagination to doing that, but as you keep staring and looking for them, you'll find them. You will find them. Okay.
Yes, sir. Yes.
Okay, let's not do this. That might be a little unfair. Let's go to, okay. All right. We can, you did a really nice job. Maybe you should stick around for one more. It's like your reward for doing so well. So why don't you look at this and say, just your overall impressions of the EKG. What's going on here? You could just kind of give me some general impressions.
Rhythm there is mostly sinus rhythm is seen in between, but there are ventricular frequency complexes also.
Okay, good, excellent. So mostly sinus rhythm with some, for purposes of this class, we'll say there's some white complex beats, and can't really, we're trying to decide here, are these SVT or VT? Are these prematures coming from the ventricle? How could these be? And you might turn back and ask me, well, you sound kind of crazy. Why aren't you calling these only PVCs? Well, because you could have a P wave right in here, and those could conduct. So you could have a sinus, normal QRS, PAC, that conducts with a left bundle, or PAC, or a PVC. So these could be PACs conducting with a bundle or PVCs. So which are they? And this one's maybe a little trickier because we don't have an AVR and so forth, but maybe I think I put this up for one particular reason. Look at this in lead 2 over here. You remember that criteria in lead 2? The time from the onset to where it peaks. If it's over 50 milliseconds, then you have a high chance that that's a PVC in origin. You see that? So you see that this here is ventricular in origin. So that's 40, 80, 120. So by the time it peaks, it's over 120 milliseconds from the onset of the QRS to the peak. When you come here, is this a left bundle type morphology beat or a right bundle type morphology beat?
Left bundle.
Left bundle. Typical or atypical? So a bit unfair because it's hard for you to do the measurements off the screen there. But you know, it's a little bit atypical. There's a little small notch there. There's a small R wave, but you know, I'm almost thinking this looks fairly typical. It's a pretty, if you actually measured it, it's probably about 80 milliseconds from where it starts to where it peaks over here. And not the best example for that because you can see the variation between that and that beat. I think I put this up to remind me about talk about the lead here. All right, we need let's take another volunteer. And I'm going to show you, let's see. Okay, here's a good one. "53-year-old presents with, he's having some chest discomfort earlier in the evening and he comes in the ER with this tracing.
Sakshi, would you like to take this?
Sure, Nitin, can you hear me?
Yes, yes.
Good morning, sir. This is it looks like a narrow QRS tachycardia with there's a P wave prior to QRS in most of the beats, but the RPR, as in the PR interval, is longer. Like RP interval is short and PR interval is long.
Okay.
Some features of right bundle branch block.
Okay.
Then there's some few beats there that's not like there. Some few beats do not have a P wave preceding to them. Like if you in the rhythm strip around fifth beat does not have a P wave or not. I can't make out a clear P wave. Yeah, this beat does not have a prior.
This one here?
Yes, sir.
Okay, okay. All right,
But,
hey. Okay. So
yes.
SVT or VT?
So I would have said SVT except for these beats. I don't know if they are like fusion beats kind of thing.
Okay, good start. Yeah, really good start there. So I want to walk back a little bit. You started out saying, you know, it looks largely narrow, and that's something to kind of watch out for. So look in all leads when you decide, before you decide whether it's narrow or wide. And I agree with you that looking down here, it looks pretty narrow. I agree with that. It looks narrow. But when you come here, you should start thinking, where does the QRS actually start and where does it end? And it's kind of strange. If you look here, and if I were to magnify this a little, and I apologize that it's hard for you on the tracing, the QRS probably starts somewhere over here and ends probably somewhere over here. Okay, and so that means, and that has to be then same true for everything else, which in fact means that the QRS here starts here and actually ends here. Do you see that? This is where the QRS ends. So all of this is QRS from here to here. So if you were looking at a telemetry rhythm strip and you just see this and say, oh, looks like a narrow complex tachycardia, then you would be completely fooled. So always look at the accompanying leads, because remember, in a 12-lead ECG, the leads are concurrent. So that means this beat is the same beat in all of these leads. In lead V1, when you have a beat, this beat corresponds to this beat, corresponds to this beat in V3. This exact same heartbeat is just being recorded in all these different leads at the same time. Does that make sense?
Yes, sir.
Okay, so now you know the QRS starts here and probably ends about here. And you know that one big box is about 200 milliseconds. So this is almost 140 millisecond, 150 millisecond QRS complex, close to maybe even a little bit more than that, okay? So it is a wide complex rhythm. It's not that fast, I'd give you that. And I do agree that it's a right bundle morphology looking wide complex tachycardia. I do agree with that. So now we have a few more points to make about it. Does it look typical or atypical? Maybe focus on this complex here and tell me whether it looks like more a candidate for an SVT or a VT, just looking at this one beat. That's all you need to look at.
So more like a VT. It looks quite typical.
Yeah, agree. And in fact, here, this fellow is actually measured for us the 164 QRS duration. So it's a wide complex, 160 milliseconds wide, and you actually have this is another thing to watch out for. You actually have a small Q wave, R, taller than R prime, okay? And then it comes back down. So this is a right bundle morphology beat, starting actually with a small Q wave. So we already know this is VT. Now, how do I know that that's a Q wave? This is actually very helpful tracing for me to see that. I don't know how close you guys are to the screen and how much you can magnify it. But when you look at the onset of the QRS here in V2, look at V2 QRS onset. You see this heavy line here? And can you see that the QRS starts to the left of that? Do you see that line? And can you tell the QRS starts to the left of that line?
Yes, sir.
Okay. So now if you were to follow that up, can you picture in your mind the QRS is actually starting there and not on the line itself? You see that? If that's so, that's how you must compare using the different leads. Look at this heavy ECG marker line. Okay. Follow that all the way down. That's at the tip of the QRS complex here. And if you follow it down, the QRS actually starts to the left of that. So that means here, this cannot be the beginning of the QRS complex. This is the beginning of the QRS complex here. So there's actually an initial Q wave, R, and R prime being smaller. So 100% nailing this as a very aberrant, a very unusual looking right bundle, much more in favor of VT than SVT. Because you're starting with a Q, and then you're ending with an R prime, R being taller than R. Just the QR itself is strongly suggestive of a right bundle complex of a VT etiology for this. So did that make sense?
Yes, sir.
Okay. Yeah, so that's a main strategy here was trying to compare different, that's the concept here that I really would like to transmit on this one tracing, is that compare always adjacent ones and use the markers to decide where the QRS starts and stops. Otherwise it's, oh, I actually did it. I magged up here to show you that. You see here now this heavy line here, and then you can see the QRS starts over here. And if you follow up here, that means the QRS starts here. So there's a little Q wave, and then it goes up like that. So that's why I magged up. I'm sorry, I didn't remember that I'd done that. Okay, Verrecky's criteria as a reminder, we look at that. Let's see if we want to do this. Maybe we'll go to this one. Oh, this is another right bundle, left bundle. Not sure what we're dealing with here. Oh, maybe someone could take this real quick, and this will help get it fairly solid. You can ignore what's going on this side of the screen. And, you know, it may be a little hard. So let me just walk through this. V1 is over here. And these complexes are the V1 complexes. Okay. AVR, remember, that's the AVR. So easy to tell that this is VT, agreed? Because look at V1, you have an R prime, they're very atypical, so consistent with VT. AVR, monophasic R wave in AVR, Verrecki criteria, this would be VT. So let's not waste too much time on that. Maybe I will go back to this one for just a second. This one is a left bundle complex morphology, agree? Same person who had the other tracing can do this one with me, just kind of walk it through. What do you think of AVR here? Is it a sharp downstroke or slow downstroke? Not that easy to tell, I would say. Maybe if you take this complex, it's fairly slow. So I'm having a hard time deciding on this. So I come down here and then I follow and I say, okay, QRS actually starts way over here. So then I know then this is a slower downstroke down in AVR and not as sharp. So more suggestive of VT than SVT. And apparently whoever was reading got this right as well. Nice. Okay. It's one of my retired partners referred one of his patients. This is actually a nice patient, 70-year-old woman who came in, who'd had chest pain about 10 days ago and comes into the ER. You know, she was just sitting there talking to us, and this was the EKG. We need a volunteer.
Ria, would you like to take this?
Yes. So this is a ECG. I can't make out the P waves. There is broad complexes with STT depression and T inversions in V4, V5, V6.
Okay. And then your decision is, what kind of rhythm is this? Is it some kind of supraventricular rhythm or a ventricular rhythm, and what to make of it? Any thoughts?
The probable ventricular rhythms.
Why do you say that?
Broad complex and I'm not sure, sir. Broad complex, that's all.
Okay. All right. Well, good start. I really like that you started out looking for the P waves. So always look for the P waves first, and see, are there any P waves? Is there a clear PR, P to QRS relationship that you can identify? I'm having trouble identifying the P waves as well. I don't know. The only one that, well, I'm not sure. Is there something here or not? I can't really tell. It's a little bumpy. So we have some kind of white complex rhythm going on. It's not very fast. And then you are trying to decide, is this a supraventricular or ventricular mechanism? Remember, we looked at a V1 to decide, is this a right bundle or a left bundle morphology? Looks like a, whoever the volunteer can continue. Is this a right or a left bundle here?
Right bundle morphology.
Right bundle morphology. Typical or atypical? A normal looking right bundle or a little odd looking?
Typical.
Yeah, hard to tell. I'm having difficulty telling because, yeah, I can't really tell if one's taller than the other. They're almost the same height. Maybe a little unusual. Maybe the initial R is actually taller than the R prime. So can't tell for sure. Now, what are these beats here? These are very interesting because these are actually what give it away. What you actually have going on here, even if you don't see a P wave, when you see these narrow QRS complexes in the middle of a white complex rhythm, these are captures, and here, some of these are actually fusion beat. Let me try to show you a good one here. Can you see here that this beat is clearly narrow compared to these beats, correct?
Yes, sir.
So you have a wide complex rhythm, and in the middle of it, you have a narrow complex single beat. So the only mechanism for this is that there is some P wave hiding in here somewhere. Probably this could even be the P wave. We don't know where it is. That then conducted down and captured the ventricle through the normal His-Purkinje system. So this is a capture right here. That's a capture. And I would also think that this is probably a fusion beat here. This looks kind of real squishy down here, a little small, low amplitude QRS. But look at this, this is pointing in the other direction. It looks like, doesn't look entirely like a conducted beat, a sinus conducted beat here. And it doesn't look entirely like a VT beat either. It looks somewhere in between, so this is a fusion. And even if you don't call this one, if you look at this in the middle of a white complex run, and you have a capture like that, that will ice it for you. That this is going to be a capture, and this would place it as ventricular mechanism, VT. Okay. All right. And maybe one more. And here, same volunteer can stick around for this one. Look at, just focus on V1. Here, I'm going to walk you through this. It looks like sinus rhythm here, P, QRS, P, QRS. And then you're given this tracing and you're asked to, your intern is asking you, are these PACs conducting with bundle branch block, or are these PVCs? What do we do for this patient? Should we give them something for ventricular arrhythmia, or what is this? And so that's your problem to decide. So look here, lead V1. Clearly, this seems to be the normal beat. This seems to be the abnormal beat. You agree?
Yes, sir.
Okay. So this one looks like the normal. This one looks like the abnormal. All right. So the normal one looks like this, and the abnormal one looks like this. And we're trying to decide, is this beat supraventricular or ventricular? So first of all, would we say this is a left bundle morphology beat or a right bundle morphology beat? This one.
It's the left bundles.
That you said that, because you decide based on the terminal part of the QRS, and the terminal part of the QRS is negative. So this is a left bundle morphology white complex beat. And And when you look at it, then it starts like this, negative, positive, and then you get an S wave. So is this typical for a left bundle morphology QRS beat, or would this be unusual for that? So is it more suggestive of supraventricular or ventricular mechanism here?
It looks atypical, sir.
Good.
It is supraventricular.
So atypical would make it ventricular. So if it was a typical left bundle, then it would be just supraventricular conducting with left bundle branch block. Does that make sense? So it's basically a normal P wave. Let's say a PAC. If a PAC was here, premature atrial beat was here, and APC or PAC, and then it conducted down and it encountered left block, then you'd get a typical left bundle here. But that doesn't seem to be the case because this one does not look like any kind of normal left bundle. It is a left bundle morphology because the terminal is negative, but it's got a QRS. And so this would be very unusual. So we could say confidently that this is in etiology, ventricular. So this is definitely a PVC. So you can turn around and tell your intern for sure, oh, those are PVCs. This is ventricular bigeminy. Okay. The other clue here, if you look in AVR criteria, from the onset to the nadir, it's about 80, 90 milliseconds. It's kind of a slow downslope here. So this is also consistent with the ventricular origin. There's a Verrecki criteria. This is the left bundle criteria. If you look here in lead 2, slow onset to reach there, and that's lead 2 criteria for making that ventricular etiology of the beat. Okay, maybe 1 or 2 last tracings just for fun, and then wrap up. Yeah, can we get to take a look at this? This is actually remember this lady, it's a 50-year-old who came in with, she's a depressed 50-year-old who came in with vomiting, kind of a bad GI, just dehydrated, and she was throwing all these arrhythmias. So we were called to see what's going on.
Reba, would you like to take this?
Hey, Nitin, we are past your time. Are we okay to do a few more tracings, or do we need to wrap up?
Sure. Couple more.
Okay.
So the rhythm is irregular.
Okay.
Not all the QRS complex, the QRS complexes, not all of them are preceded by a P wave.
Good.
If you look at the E1 complex, the morphology looks more of a LVB type.
Good.
So the terminal part is negative.
Yeah.
And looking at the AVR lead also, the downsloping of that Q is quite slow.
Yep. Very good. Excellent. So all that is in favor of
Of a V, more of a VTAC.
more of a VT. Good. Very good. Yeah. And so the only other thing I'd comment, looks like a little bit of variation between these 3 beats. It's like something weird going on here. They all look slightly different. So a little short run of VT. And this is the baseline tracing. Let me see if this is helpful for you or not. May or not be helpful. Let me go to one more. All right. Any thoughts now? What kind of rhythm is that on the, this is what you looked at earlier, and this is the rest of the story. It's not a trick question. I mean, what are we seeing on the right side of the screen here?
It's become a wide complex tachycardia, which
Good.
is most looking regular.
Yeah, looks very irregular, huh? Looks very irregular. And look at these. Here pointing downwards here pointing positive,
Oh,
here negative.
okay. It's like spiraling.
Correct. Right. So axis is shifting around. So this is torsades. Yeah. Okay. And then now come back and look at this here. We have more clues now. So 200, 400, 550 maybe milliseconds, maybe 500 plus millisecond QT interval from there all the way to there. Huh? So long QT with big broad-based T wave, typical for long QT type 1 with a big broad-based T wave, commonest type of long QT abnormalities in KCNQ1 or LQT1. So let me see if I know what I was looking at for here. Okay. Yeah. And we spent some time with those. So let's look at this one here for just, let's see if I have any, I have some names, numbers for your leads over here. Let's call this one, this will be V1. And I think in, this may be AVR down here and it's kind of smushed. So just look at V1 and then give me some comments on your, on this. The same person can take this one as well.
Then V1, it starts off with a sinus rhythm.
Yep.
And then towards the middle of the tracing, it becomes a broad complex tachycardia.
Right. So is it a short run of VT or a short run of SVT with bundle branch block is the question?
It looks more of a VT.
Okay. The complex in, let's say this is V1, this would be an R prime. And I think it's always tough when these things are kind of smushed together like that, the R and the R prime. But this is probably an R prime. It could be almost a monophasic R wave there, I agree. So maybe VT, maybe SVT. So then you have to start digging for all the other clues. So now then come and look to the left of what's going on here. You have P wave, P wave, P wave. And then is this one narrow or wide? This? This one narrow or wide?
This is narrow.
These two are narrow. So
Yes,
what on earth why are these now faster? Look, this is the intrinsic sinus rate. What's going on over here? P, P, P. And this was the sinus rhythm P to P interval. So you see atrial tachycardia has started already here. Do you see that?
Yes, sir.
And then it's warming up. Atrial tach gets faster and faster, and then it starts conducting with bundle branch block. So this is a SVT with bundle branch block. So remember, anytime you see you're given a tracing, always look for how it starts and how it ends. Sometimes your clue will be in how it ends, and sometimes the clue will be in how it starts. And here, you know that, well, okay, fine, this could be VT, but if this is VT, then why did this rhythm suddenly speed up over here with narrow complexes? You see that?
Yes, sir.
Yeah. So then ventricular tachycardia already warming up over here, and then you know what I mean by warming up. It's just an atrial tachycardia starting a little bit slower and speeding up as it moves through to the right. And you can actually conclude that because, otherwise there's no other reason for two rhythms to be right next to each other, an SVT and a VT for no reason. So then this would be then SVT conducting with bundle branch block. And actually, you have these types of patients, so you should look at one of this. This is a patient of mine with sarcoid who came to ER with this rhythm. She was fainted a couple of times at home and then came in. I'm going to just walk through it quickly just for purpose of time. But you could see here, if I just look over here at the V1 complex, you see just a big monophasic R wave. I can't really tell, is it R or R prime there? Big fat R wave there, okay. Most likely the initial R is taller than the R prime, already atypical, more suggestive of VT. And when you look here in the AVR criteria, you have an R, S, R prime, like that, most likely. And again, a little bit atypical looking compared to the usual AVR criteria. To those, the rhythm was VT. This patient had an underlying pacemaker as well. Paced rhythm there. Let me see if I have one. Okay. Maybe we'll, let's get a quick volunteer on this one.
Sakshi, would you like to take this?
Yes, sir. This looks like a sinus tachycardia with it's irregularly irregular. Okay, just a second. So it looks like it's an irregularly irregular tachycardia with
Good.
I can't see P wave properly, sir.
Good. Okay. So what's your guess? Irregularly irregular tachycardia.
Atrial fibrillation with a fast ventricular rate.
Good. Very good. And then now you have to decide, is this AFib with a fast ventricular rate? And if so, it looks a little bit wide. Is this a AFib conducting with bundle branch block? Or is it some kind of irregular VT? I would grant you right off that it doesn't look that wide, does it? It's probably barely 120 milliseconds. So just about a wide complex tachycardia, okay? And irregularly irregular, atrial fibrillation, you've correctly identified the underlying rhythm as AFib here. And I think you've already kind of got your broad diagnosis here, which is atrial fib conducting with bundle branch block. Because you have a typical RS R prime here. So RS R prime, a typical right bundle complex here, and similar in lead AVR. So just AFib conducting with bundle branch block. Good, good, well done. Okay, well, let's wrap up right there, and thank you all, and enjoyed doing that series with you. if you have any questions, I'm happy to answer. Otherwise, we'll cut you loose to your next session or class, or I'm sorry, back to your clinics and patients.
Vijay, thank you very much. This is Tambu here.
Hi, Tambu.
Thank you so much. We really enjoyed these sessions you've taken for us. We wish it could be much longer and every week for a year or so, but that's not possible. but I'm really grateful that you accepted our offer, and you're busy. You've got so many things to do. But I was so happy to hear that you were so happy to hear from us and willing to take these classes. We've really enjoyed them. They're recorded on a YouTube channel, and we'll send you the YouTube link so that you can share it with anybody if they want to hear. And once again, on behalf of the whole Department of Medicine, thank you very much, Vijay. We're really honored, and thank you.
Oh, thank you so much, Thambu. I really enjoyed doing it, and the PGs were great. They all did a great job. I really appreciate that they volunteered and stepped up and did it. Took the tracings. It's nice. It's always hard to. It's always a little stressful to volunteer in public to read some squiggly lines. So that's really nice. I hope it helped them both for their careers and their exams and looking after sick people in the wards. And yeah, I just really enjoyed it. And so